Welcome back to OMFS Essentials, concise knowledge for the modern maxillofacial surgeon. In today's episode, we shift our focus from closure to access, discussing the principal extraoral incisions used in maxillofacial surgery. Selecting the correct incision is a foundational skill, balancing the need for optimal surgical exposure with minimizing visible scarring and protecting vital neurovascular structures. Number 1. Coronal approaches: uni, hemi, and bicoronal. These incisions provide superior access to the upper face, orbit, and zygomatic complex. The coronal incision principles. The design is dictated by two main factors: the patient's hairline and the extent of inferior access required. The incision is typically made through the skin, subcutaneous tissue, and galea, leading into the subgaleal plane overlying the pericranium. Hemicoronal approach. Its location begins in the preauricular area on the operative side and curves forward, ending just posterior to the midline hairline. This curve provides necessary relaxation for flap retraction. Its extension can be inferior, becoming a preauricular incision down to the ear lobule, allowing exposure to the zygomatic arch and the temporomandibular joint, or TMJ. Its indications are primarily for managing unilateral midface fractures involving the frontozygomatic suture, orbital rim, or lateral orbital wall. Its precautions are to avoid tearing the pericranium during dissection at the forehead where it is adherent to the frontalis muscle. The bicoronal approach is a much broader incision, extending from one superior temporal line to the other, often called a hairband incision. Its design note for males is that in anticipating future hairline recession, the incision line is often curved in a zigzag manner on the cranial side to better conceal the scar later. Its indications are essential for managing bilateral midface fractures, bilateral TMJ trauma, or conditions requiring extensive exposure to the nasoethmoidal area, superior orbital rim, and lateral orbital walls on both sides. Number 2. Transfacial approaches to the mandible. These incisions grant direct access to the posterior body, angle, and ramus of the mandible. Its standard submandibular and Risdon's approach. The incision is strategically placed approximately 2 centimeters or 2 finger breadths below the inferior border of the mandible. The reasoning is to avoid injury to the marginal mandibular branch of the facial nerve. Its Risdon's modification specifically curls around the angle of the mandible to provide superior access to the angle and ramus region. Its indications are extraoral access for mandibular angle and ramus fractures, cysts, tumors, or complex pathology not amenable to an intraoral approach. Its precautions are to maintain the 1.5 to 2 centimeter safety margin to protect the marginal mandibular nerve. Placing the incision within a natural neck crease minimizes the visibility of the final scar. The pre-op palpation of the facial artery is advised to avoid accidental injury. Its retromandibular incision begins about 0.5 centimeters below the ear lobule and runs 3 to 3.5 centimeters inferiorly, placed just behind the posterior border of the mandibular ramus. Its indications are primarily used for surgeries involving the condylar neck and ramus. Its precautions, due to its proximity, extreme care to avoid injury to the main trunk of the facial nerve and the retromandibular vein. Number 3. Transfacial incisions to the midface. These complex incisions are used for extensive maxillary and nasal access, particularly in tumor and trauma surgery. The lateral rhinotomy, it starts below the inner margin of the eyebrow, extends down along the nasomaxillary groove, and curves around the nasal ala to enter the nose. Its indications provides direct access to the nasal cavity and the maxillary antrum for complex procedures like open rhinoplasties or tumor resections. The Weber-Ferguson incision is an extension of the lateral rhinotomy, used for maxillectomy procedures. The key difference from a standard rhinotomy is that the upper lip is split in the area of the philtrum to gain wider access. Its extensions, the Lynch extension, adds a cut from the medial canthus to the medial end of the upper eyebrow for greater access to the medial orbital wall. The subciliary extension extends the incision laterally in the crease beneath the inferior eyelid. Its indications are used for partial, subtotal, or total maxillectomy. Its critical precaution is that when combining the infraorbital and lateral nasal parts of the incision, the angle formed at the junction must be obtuse, or rounded. A sharp or acute angle creates a critically narrow flap tip, which significantly increases the risk of flap necrosis. Summary: extraoral incisions are chosen based on the precise anatomical area needed for exposure. Coronal, for the upper face, orbit, and zygomatic. Submandibular or retromandibular, for the mandibular angle, ramus, and condyle. Rhinotomy or Weber-Ferguson, for the maxilla and nasal cavity. Mastery of these approaches requires an intimate understanding of the underlying anatomy to prevent neural injury, ensure adequate working space, and preserve cosmetic outcome. Choosing the right incision is the first critical step towards a successful surgery. By meticulously planning the access, we set the stage for safe dissection and optimal functional results. You've been listening to OMFS Essentials. Subscribe for more concise, evidence-based episodes, and as always, keep mastering the essentials.